All right, picking up where we left off, we're moving on into endotracheal intubation, which is what we're really talking about, isn't it? We're talking about airway management. And as up to this point, I'd like to think that we're all good at managing an airway in a minimum of a BLS maneuver. In the state of Oklahoma, if you're an advanced, as you know, you also have the ability to place an advanced airway, which is not very common in a lot of other states that are nationally registered. So if you've already gone through advanced, then you're hopefully proficient as well as placing one of these advanced airways that we're going to get into. If not, though, here's what we're going to talk about. So endotracheal intubation essentially is when it's passing an ET tube through the glottic opening and sealing the tube with a cuff inflated against the tracheal wall. So a couple of different ways that we're able to accomplish this. Orotracheal, that's passed into the trachea through the mouth, and then the nasotracheal is going to be passed into the trachea through the nose. What we're saying is, kind of what we're doing here is the intubation. That's the best means of achieving complete airway control. There's not another way that completely protects it the same way that a King airway does it. King does a good job, but it does not protect the airway the same way that an intubation does, endotracheal intubation. So it wasn't that long ago, and you probably might still see it. It was kind of what was called the gold standard of airway management, because that is what protected airways, and that's what we did. So some of its advantage, it does have some different advantages, and it's the best way to secure an airway. And by doing that, you're protecting against aspiration. And then it's an alternative to an IV or an IO route. But there's only certain meds for one thing that you can give through there, as well as really, unless you just have weird protocols or you have a really weird patient, you should be able to place an IO. This was something that was a little more common, 10 or 15 years ago, that you might give meds through the tube. But really since the advent of the IO drill for an adult, we're not pushing meds typically through the tube. A quick rundown of those, if you don't remember, through pharmacology, you had a acronym, I believe it's called acronym, of lean, lidocaine, epinephrine, atropine, and Narcan. Those are the four meds that you could give down the tube, those four and only those four. So whereas an IO, you're able to do any meds that you push through an IV, you're not able to do that as much as with a tube. So moving on down, disadvantages, obviously you need to have some special equipment. You are bypassing some of these functions, so that we talk about with the upper airway, meaning the warming of air, the filtering of the air, the humidifying, all of those physiological functions we're actually bypassing by placing an endotracheal tube. So some of the complications, and there are complications. There's bleeding is definitely a chance. Hypoxia, and to be honest with you, that's, in my opinion, probably done most of the time as an operator error. So what I mean by that is a medic discretion, because they won't give up the airway, or they're not hyperoxygenating them prior to opening their mouth and placing the blade in their mouth. That's something that we have, for the most part, some control over. And to be honest with you, that's why a lot of places are looking at getting rid of this skill for paramedics, is because we're not doing a very responsible job of getting these patients intubated. So moving on, laryngeal swelling, a lot of, and spasm as well. We talked about that just a little bit ago, but a lot of that has to do with trauma, a lot of it, and meaning the trauma that we're creating, a lot of it has to do with irritation from the blade, rubbing against the larynx, those kind of things. Vocal cord damage as well, mucosal necrosis. So vocal cord damage can be everything from the blade inserted improperly to the tube banging in on the vocal cords, as well as it can definitely cause this part of this next part, which is mucosal necrosis. If you do not have the tube placed properly and you go and inflate the bulb, and part of the bulb is within the vocal cords, that has a really good chance and tendency to cause some damage. The necrosis of the mucosa is the same thing. We have a pretty distinct amount of air that we need to put in there. And I'm not saying distinct meaning that it's a very set number at 5 mils of air. But what we do need to do is put enough air in there to cause no air to move around that bulb. So what happens a lot of times is we overinflate that bulb, and that's what causes that mucosal necrosis. And then barotrauma as well, so some trauma within the chest cavity. So endotracheal tubes, basic structures, you're probably somewhat familiar with these, but we have the proximal end, and then moving on down, we have the tube, the cuff and the pilot balloon, and then the distal tip. So these things are equipped with an adapter. It allows it to be attached to basically any ventilation device, and it also includes an inflation port that you see in this picture with the pilot balloon. So, we'll once we place that properly, actually prior to placing it, we're going to check it to make sure that bulb or that cuff inflates properly, and then once placed, we're also going to inflate that cuff. So, one of the things that we'll talk about as we learn how to do this is that it has a beveled tip on it. That's to help with insertion. And then in case you see it or you hear about it, the opening on the side, that's called a Murphy's eye. And what that does is it enables ventilation to occur even if that tip has become occluded. And as you can imagine, some of the patients have a lot of stuff that's in their lungs, and you can get mucus plugs and things like that will clog those things up. So even if that does happen through that Murphy's eye, hopefully, and it should, continue to ventilate the patient. So tube sizes, we can see on here we have a 2.5 to a 9. If you've not seen a 9, you ought to see that. It's pretty much, if you haven't, imagine your garden hose, it's pretty much that size. And then your length, you have 12 to 32 centimeters in length. So we have so many variances is because you want to make sure that it is fitted properly. So if a tube is too small, it'll lead to increased resistance to airflow and difficulty in ventilating. And you can go back to thinking about your airways or thinking about your circulatory system. And when you have a narrow diameter, then you have increased resistance. As well as if a tube is too large, number one, it can be difficult to insert. So if you're trying to put a 9.0, down a 130-pound female, probably, unless something is just, they're an anomaly, it's probably not going to work. But what is going to happen is you're going to cause probably a tremendous amount of trauma within that patient. So a stylet, I'm going to ask you to watch the video that I've placed in here. It's a really good video, but as the doc talks about there, some people prefer stylets and some don't. From what I understand, one of the anesthesiologists over at Shawnee, or nurse anesthetist, I guess, they insist that you don't use a stylet because that's the way they do it. So make sure that you learn with them on how to properly do this. Me personally, I like a stylet. One of the things the number one point you see there is it molds and maintains the shape of the tube. So what that does is allows you to put a little natural curve into it, or it's a little bit more rigid whenever you get into a difficult airway, and it just helps you to push that tube through. So also you'll see that it should be lubricated for removal. Typically a lot of times I don't see that, but through our curriculum it's saying we should use a water-soluble gel to help with its removal. As long as the thing's not too boogered up and all bent and wacky looking, you shouldn't have a hard time getting that thing out. One important thing, and I'll tell you this, is to make sure you have a good grasp on that tube before you go to pull out, because you will pull that thing right out with the stylet if there's any kind of bend in it. So you see the other point, end should be bent to form a gentle curve. Now let's be honest, many times that's not going to be the case. Many times it's going to might require a little bit of a more aggressive bend, more of a hockey stick kind of curve to it. A lot of times, depending upon whether they're anterior or posterior, and how, a lot of times their airways are really big, meaning their neck is really big and meaty. It's going to be a hard intubation. So then you can see the ends should rest at least ½ inch from the end of the endotracheal tube. So we're still talking about that stylet. We don't want it to go out the end, as you can imagine. That will definitely cause some trauma. We're not looking for that to happen. We want to keep that stylet within the tube and to where it's useful. Whoops, wrong button. Pediatric patients, 2.5 to 4.5 millimeter tubes used. So when we say just a 2.5, that's what we're talking about, 2.5 millimeters. You'll see the point funnel-shaped cricoid ring forms an anatomic seal. So for the most part, you're not going to see cuffs in these little kiddo tubes because they're not needed. Now that changes as we grow older and you don't have that seal any longer, so that's why we end up having to put a balloon on there, a pilot balloon. So you don't get a cuff on there on the kiddos, and it will seal itself properly, which is pretty nice. Anatomic clues can determine the tube size. And you see a couple of points here. Internal diameter of the nostril approximates the diameter of the glottic opening. So when you look at one of their nostrils, typically the right is what I'd always use. If you can say that, you can fit, say, that size, the diameter is a 7.0, then they should be able to handle that 7.0. The way that I also like to do it is a point here which we talk about the pinky finger, that you're able to use the same size tube as the pinky finger. And this last point is a really good thing to do, get in a habit of, because we need to be prepared. But always have at least a size above and below the size that you think it is. So if you're going to do a 7.0, always have a 6.5 and a 7.5 handy. They don't have to be opened and sitting on your patient's chest where you're dirtying them up and wasting them, but always have them handy. So laryngoscope, if you're unaware what that is, this is what we're talking about here, is the laryngoscope. It's required to perform an oral tracheal intubation by direct laryngoscopy. So it consists of a handle and then all of the different blades that go along with it. Don't get so used to just one that you require one particular handle. We have a couple of different handles here at the school, so I would suggest and recommend that you get to be good at all of them because they're not always the same. So the handle contains the power source, contains the power source for the light of the blade. Most of them you're going to open up right here. You're going to put your batteries down in here. As well as when the blade is perpendicular, the light shines near the blade's tip. So our lights, these are going to be your light right here. And we have some now that have LED bulbs in them and a lot of different things, a lot of different styles out there. So two different types of blades, and as Dr. Brave talked about, you need to be good at both. So if you come out of here saying, I only use a Mac blade, meaning your curved blade, then we've done something wrong because you need to be good at both blades. So we're going to teach you how to use both and the advantages of both, but just talking about them right now, at that straight blade, that tip will extend beneath the epiglottis and actually lift it up. So I've used these multiple times with little kids. That seems to be good. As well as this was always kind of my go-to blade because I used the same technique that Dr. Brave talked about, where you just kind of buried it in, lift it up, elevated, and then you just start backing off until your cords, until everything drops down. That's a little bit more, can become a little bit more problematic, and it's a little bit more muscular of a movement because you're having to use a little more force. It can be a little bit traumatic on your patient as well. And then we have our curved blades. If you'll notice, curve has a C and the Mac has a C. They're also in the shape of a curve. So one easy way to remember it. But the curve conforms to the tongue and the pharynx, and we talk about that. You're just gonna guide that thing down along the border or the edge of the tongue, and you're gonna allow that tongue to kind of be your guide. So the tip is placed in the vallecula. Go back to your anatomy if you're unsure of where that is, but it actually indirectly lifts the epiglottis to expose those vocal cords for you, and that's where we're gonna place our tube. So blade sizes, 0 to a 4, 0, 1, and 2 appropriate for infants and children. Now, most people do kind of have a go-to, so they like to set their kit up. Most times we always go through your kit at the beginning of shift, and maybe you put on a 3 Mac or you put on a 3 miller, and that's, I think always a safe bet. A 4 is going to be pretty long, other than for someone with a bigger neck, but that gives you a kind of your go-to. So pediatric patients, based on the age or the height, depending upon the patient. Remember, these are on your Broslow tape too. They should tell you what your blade size and your tube size is recommended. Your protocols might have that listed as well. And then with adults, it's going to be based upon experience. So when you see that, right away we kind of know after you've done a number of these that, that's probably about an 8.0, those bigger neck people. But it's very easy to get tricked. So make sure that you always have additional tubes that you can use. The McGill forceps, we've talked a little bit about them earlier, but they're going to remove any airway obstruction under direct visualization. They can also guide the tip of the tube through the glottic opening if you're having a hard time, as well as using a bougie, which you'll notice in the video. And I can't remember if we cover that in this newer curriculum or not, but we're going to cover that in the lab. So oral tracheal intubation by direct laryngoscopy. There we go. ET tube inserted through the mouth and into the trachea while visualizing the glottic opening with a laryngoscope. And who needs that? Well, let's talk about that. Airway control needed due to coma, respiratory, or cardiac arrest. So any kind of, if they're unresponsive, if they have respiratory, cardiac arrest, ventilatory support before impending respiratory failure. So if somebody's going to be kind of giving up, they're telling you, I can't continue to breathe like this for very long, then you're going to need to do that. As well as an absence of a gag reflex, that means they don't have that protective mechanism to take care of things for you. Traumatic brain injury has multiple pieces. It can be anything from a gag reflex that's not there to the respiratory center being jacked up and them not breathing properly. So unresponsiveness shouldn't need to go into. Obviously, they're incapable, or for the most part, unable to protect their airway. And then impending airway compromise. So if they've had some burns or some trauma to their airway and that it's going to be swelling up, it's good to go ahead and take care of that thing. And then medication administration. So that's really our last resort, and unless something's gone horribly wrong, we shouldn't really be doing it for that particular cause. Contraindications for oral tracheal intubation or endotracheal intubation: intact gag reflex, inability to open the mouth. So it could be anything from trauma to some kind of pathologic condition or some kind of congenital issue that will not allow them to open it up. The inability to see the glottic opening, and then copious secretions, vomitus, or blood in the airway. But we can fix that, right? So we're able to go ahead and start suctioning that stuff out and get it out to where we can start seeing things better. Intubation can expose you to body fluids. Hopefully you can imagine that stuff will come flying out of there. So I always suggest that you use one of the masks, maybe with the face cover that allows you to breathe through it as well. And then of course you're going to need to use gloves. Remember they're coughing up stuff out of their lungs and their stomach, so that's not really stuff that you want all over you. So pre-oxygenation, that's one of the biggest steps, in my opinion, that's extremely important here. We're talking about 2 to 3 minutes for apneic or hypoventilating patient. You also, at times, we'll talk about it in lab, but we can throw a nasal cannula on somebody as well as while we're starting to ventilate them. Just get that much more oxygen going. You can flow that at a high rate, and that the pressure that it creates will cause some O2 transfer. So that's a really good little tip there. But it prevents hypoxia from occurring, talking about pre-oxygenation. And then you want to monitor this and achieve as close to 100 as possible, because you got to understand that whether they're not breathing or whether they are breathing or not, so meaning if you take away their airway or if they've just stopped breathing on their own, they will desat eventually. With that little tip of the nasal cannula, that will help to not allow them to desat very early. But one thing I suggest is that you hold your breath while you're starting to do this procedure, and whenever you need to breathe, so does your patient. So when it's time for you to breathe, you need to pull that laryngoscope out of their mouth and start ventilating them again. So we're not going to go into a lot of this stuff with the, we've covered the anatomy and physiology at the beginning. So we'll go into a little bit here, but not that much of anatomy. But here it's kind of important because we're talking about positioning the patient. So you can see that as this is going to be our angles here, that we're talking about. So when you have a more of a neutral or hypoic, I guess you'd say hypoextended, or I guess it'd be flexed actually, a flex position, you're not going to be able to place that airway. So we need to get their head into the right position. So we're going to be able to visualize the airway and be able to pass that tube. Because by not having them in the right position, that makes this an extremely difficult job. One of the things that, in my opinion, is the most important thing is this right here, is positioning our patient. It can make this task very easy, or it can make it very hard. So one of the things that we want to do, and on here, we want to use the stiffing position at a minimum, and maybe even hyperextend it just a little bit. So, we see that it's a 20-degree extension of the atlanto-occipital joint, 30-degree flexion at C6 and 7, but we want to elevate the head and or the neck until the ear is at the level of the sternum, and that right there is really one of the big points, is that if we need to elevate that, we continue to elevate it until we get the ear at the level of the sternum, because that allows us to be able to see things a whole lot easier. So as you can see here, we're going to position ourselves at the head. You're always going to use your left hand. If you're unaware of that, you're always going to use your left hand with your laryngoscope. So you want to, after that, they should have been, we're talking about the process now, the actual intervention. So you should have already had yourself or your partner, they should have already been ventilating this patient, hopefully pre-oxygenating this patient. So you're going to grab it with your left hand and obviously direct your partner to stop ventilations. And then as the doc on the video talked about, if you're able to do that, and you should be able to, is the scissor using your thumb and your forefinger. You should be able to use those right on the molars and open that airway up. And then you open with a tongue jaw lift. So inserting your blade, we're going to insert into the right side of the mouth, and we're going to sweep to the left. So one thing that I've found, that I've talked a little bit about with the traditional class, is as we go over to the left, number one is if you'll turn you're going to actually start sweeping the tongue, and then you're going to roll your blade over to about 45 degrees, and then you're going to follow that angle of where your handle is forward. That really starts to open up the airway and allows you to really see everything. So we're going to start sweeping that tongue to the left and slowly advance the blade. This is a time where we can start breaking teeth, and I can tell you that will get you probably a really good write-up, or at least a minimum of a complaint if you go and you break Mima's teeth. So you want to be very careful, as the doc said on the video, going in and going out with your blade so that we don't break it. We do not want to crank back, because that is we don't want to use those teeth as a fulcrum, meaning that little spot to where we're going to rotate things on, because that's a really good way to break things. You don't want to pry back on that laryngoscope. So that's what we're hoping to see right there, is we're wanting to see that within that glottic opening, we're wanting to see the cords. These are going to be your vocal cords. That's where we're going for. You can see these cartilaginous rings in here where we're going to place our tube. So depending upon the blade that you used, if you have a curved blade, you're going to place it in the vallecular space, or the straight blade goes directly underneath the epiglottis, and then we're going to gently lift until the glottic opening is in full view. So as you reposition your hand and you start moving, hopefully those cords are going to come into view, and you're going to be able to see things. That's the idea. So this is the bougie right here that you will also use in lab. It's a really nice way if you're having a little bit difficult time intubating and you can barely see the cords. You can slip that in there, and then you just slip your tube right down on top of it. We're going to be doing this in lab as well, but this bougie is a really nice thing to have, and hopefully your ambulance services have these. So there's a number of different ways that you can do it, but you're still going to want to get everything out of the way with your laryngoscope blade, and then you'll drop your bougie down into the trachea, and then once you've dropped that, you're then going to put your tube over the bougie and then continue just to feed it down in there. So ET tube insertion. So pick up the ET tube, hold it near the connector as you would a pencil. That should be pretty easy. We don't want to hold it down at the very bottom, but we want to have it more at the very top. Insert from the right corner of the mouth through the vocal cords, and then we want to go about 1 to 2 centimeters past the vocal cords. Some companies have made nice little marks for us, and you'll have to determine that, but my best guess is that we really need to be able to see that and to be able to know that we're going beyond the vocal cords, make sure that cuff goes past those vocal cords, and we know that it's placed properly. And then once we do that, we're going to remove the blade. Now, the thing is, we need to hold this tube securely with your hand. I'm going to warn you now that while you're in lab, if you let go of that tube prior to it getting secured with a tube tamer or a commercial device, I am going to pull it, or another adjunct is going to pull it, and I'm going to instruct your classmates to pull it as well. And if they don't, then there's going to be 2 people that are having problems, because we need to get in the habit of protecting these things. Once you've worked hard at getting this airway, let's not mess it up. So once you've got it, let's protect it and make sure that we do not lose that sucker because we're being lazy or we're just being lackadaisical and not thinking about it. So we're going to hold that nice and tight. Then we're going to remove the stylet from the tube, and then you're going to inflate that cuff. I think I'm a little behind here. Then we're going to inflate that cuff somewhere in the neighborhood of 5 to 10 mils of air to fill up that cuff. And if you do leave the syringe on there, the back pressure will cause some of that air to fill into your syringe. So you need to go ahead and get that syringe off of there. Also, another pet peeve that I'll let you know about that we don't want going on in lab is once you've removed the blade out of the mouth, go ahead and close it up. All you have to do is touch it to the counter or whatever surface that the patient is on, just to close the blade. It closes up, turns the light off, and it's just kind of one of those things, to me anyways, that we need to just take care of our stuff. And in the field, it's a good habit to do as well, because those things can get left on and then we just burn up batteries, and it's just kind of a hassle. So then we're going to while we're still holding the tube in our hands and we've already inflated the cuff, we are going to have our assistant, but obviously our EMT, attach the bag mask device to the ET tube and start ventilations. So depending upon whether you need to do capnography, if you work at a service that has inline capnography, that's when we'd put that guy on. And then as the first ventilation is delivered, we're going to make sure that the patient's chest rises with each ventilation. So we're going to be looking for chest rise and fall. Now after that, we're going to go ahead and put our stethoscope on, and we're going to start listening to both lungs, and then we're also going to listen to the stomach. If we've done it right, we should hear air in both lungs, and we should hear nothing in the stomach. Sometimes that noise will transfer, and you might hear a little bit in the belly, but the key is that if you're ventilating them into the lungs, you're going to have chest rise and fall, you're going to have nice strong sounds. You might have some light sounds down in the belly, and that's okay. It's just something that happens. But you want to definitely have good lung sounds. And then we're going to start what will determine our ventilation rate is going to be, as you see here, depending upon our patient. So an adult with a pulse, 10 to 12 breaths a minute, an infant child with a pulse, 12 to 20 breaths a minute, or a patient in cardiac arrest, 8 to 10 breaths a minute. So that's about 1 breath every 6 to 8 seconds. Now remember, this is different than maybe what the healthcare provider or some of these other CPRs styles is. We're not going to be counting 15 to 1 and 30 to 2 and all of that, ventilations and stopping. This thing is just going to be happening. So there's going to be compressions and ventilations going on at the same time. Compressions are basically just going to be non-stop, so somewhere greater than 100 to 120. And ventilations are just going to follow this pattern of, with a cardiac arrest patient, it's going to be 8 to 10 breaths a minute, and at times it's going to happen at the same time, but that's okay. That's how we do things. And then a really big thing, we want to make sure or confirm that we've put the tube in the right place. So number one thing we can do is visualize that tube passing through those vocal cords, which is pretty important. We want to make sure that that lets us know that we put it into the trachea. And then we'll auscultate. That's our next step. So unequal or absent breath sounds tells us a couple of different things. Esophageal placement, or we put it in the gut. Right main stem bronchus placement, so we might hear very strong breath sounds over the right and very diminished over the left. And what's probably happened is we've slid that thing right into the right main stem, and now we're ventilating one lung versus two. What we're going to do then is we're going to back that guy out just a little bit and then re-listen. Pneumothorax, maybe we caused it or they had it, and we're ventilating one lung even though it's placed correctly, or a bronchial obstruction of some type, whether it's a mucus plug or a foreign body or something along those lines. So talking about auscultation, we want bilateral absent breath sounds or gurgling over the epigastrum. The esophagus was intubated. We want to get that tube out of there. It's not okay for it to be in there. There's no air transfer, so we've got to get that thing out. And we may need to suction the airway because we may have pressurized that cavity and stuff may come up after that. So once we've cleared the airway, we're going to ventilate them some more because we've done kind of a poor job of ventilating them at that point. Well, once we intubated his belly, we're going to reoxygenate him, and then we're going to go again. So like I said a minute ago, if you only have those sounds on the right, that means a tube's been advanced too far. So we're just going to reposition the tube. You're going to back it up a couple of centimeters, and you're going to go ahead and listen to your lung sounds again. But if everything's went well, then we are going to the bag mask device should be easy to compress, so we should have what you might hear as good lung compliance, meaning it's easy to empty out that bag. It's not meeting resistance. And then you should see corresponding chest expansion. So, you should have some chest rise and fall as you're bagging that patient. That's a good sign that we've done our job correctly. Now, if you start having increased resistance or decreased lung compliance, then you may have put it in the gut. You may have gastric distension, whereas I kind of told you earlier about we're ventilating their belly, and now we're having a hard time getting air into their lungs because everything is so big. Or we've put it into their gut, or they have a tension pneumo, which is also not allowing us to ventilate them properly. So we move on, we start talking about some continuous waveform capnography. So in addition to our clinical assessment, this is probably one of the most reliable ways of confirming and monitoring whether we really put that into the right place. So we're going to attach capnography, that T-piece when the bag valvascus device is attached to the ET tube, and then we're going to look to make sure that we did by looking at our waveforms. Sometimes you may not work in a place that has that, so we're also going to look for, remember that colorimetric device, when we say gold is golden, we're going to look to see that we have that gold color change. These things are not that popular anymore. What happens is you put a plunger down there with a syringe on top of the tube, and if you, as you can see, if the tube's in the trachea, the plunger does not move. If the tube is in the esophagus, then the plunger moves back. You're able to draw back. If I remember correctly, what happens is it actually not breaks down the airway, but collapses the airway, and it allows it to shut down on itself. So that's why you're not able to pull back. And the esophagus, it's just a big hollow cavity. So that's why it allows it to do it that way. And then the bulb model, same kind of thing. You put the tube in the esophagus. If you have, the bulb remains collapsed. If the tube's in the trachea, the bulb briskly expands after you've tried to squeeze the bulb. Those are things that you don't see very often. One thing we talked about, securing the tube. Never take your hand off that tube before securing with an appropriate device. So if you hear me say the word tube tamer, that's what we called them when they first came out. So, I'm not sure what the jargon is anymore, but and that little commercial device, that's what we're talking about. Make sure that it's secured well. And you don't want to have it wrenched down too tight because it makes it really hard to ventilate somebody like that. So you note the centimeter marking on the ET tube. You need to know what that centimeter marking is, because that way you can pass that on to RT or to the ED doc, as well as I'm going to ask you in your documentation that you document where you put it at the corner of the mouth. So if it was at 23 centimeters at the corner of the mouth, the tube is, that's what you'll need to write on your documentation on every intubation. When you do your OR tubes, when you drop one out in the field, if you get lucky enough to do one in the ER, wherever, I'm going to ask you that you, or insist that you put that on there, because it's a good habit to do. It also make sure that you have something to compare to. So if 23 was right, you know you had good breath sounds, you know it was above the carina, within the chest, to be able to ventilate both lungs, and you look down and you're not getting equal chest rise and fall, and you look at your tube, you know that 23 was right, and that's where you're at now. That's just another tool to then start figuring things out. So remove the bag mask device, position the tube in the center of the mouth, place the securing device over the tube depending upon what kind of device you have, and then just lock her down. So some of them, one of the nice things is these built-in bite blocks. With that built-in bite block, a lot of times when people start coming around, they may end up biting on that tube, or if they have a seizure or whatever, they may start biting on the tube, and that can become a problem. ACLS, I don't remember if they still talk about it in this newer curriculum, but at one point we were being suggested to go ahead and put a collar or at least blocks on your patient, head blocks. That way it limits the, kind of immobilizes their head to not move that much. So hopefully it's going to keep that tube a little more secure than if their head's able to move around. So we want to minimize their head movement as much as we can. All right, moving on to orotracheal intubation by video. So what this does is it allows you to be able to see, get a little bit better visual of the airway. What's weird is, as you see that last point, it does require better hand-to-eye coordination. And it's weird because you're looking at this little screen that's, for the most part, not going to be right where the airway is. So it takes a little bit of getting used to it, but you can do it, and it's a good confirmation tool, as well as it's something that you're able to record and attach to a electronic file. Types, you have a separate video monitor, and then some of them are attached to the laryngoscope itself. Feature single-use blades of various sizes. Some do require the displacement of the tongue. Others are inserted in the midline, of the mouth, and just simply follow the curvature of the tongue. But you see here a couple of different styles that's out there, and you can imagine it's going to be pretty handy at times. But like I said, sometimes it's a really neat concept, but sometimes it's not as easy as we'd like to think it was. Nasotracheal intubation. So this is something that is not as popular as it used to be. What used to happen a lot was you might have somebody that was in CHF, but they were still alert enough that you were not able to do an orotracheal intubation. And before, a lot of services had RSI, or drug-assisted intubation. So you might have to do a nasotracheal intubation. Now with the advent of CPAP, we don't do those probably near as much as we used to, but it's the insertion of a tube into the trachea through the nose. So when is it indicated? It's indicated for breathing spontaneously, but requires definitive airway management. One of the things you might seem weird is that it says breathing spontaneously, but that's going to be able to give you the sound that you need to know when to advance the airway. So it's kind of important that they are breathing, because you're going to wait for that epiglottis for everything to move and everything to open up and allow you to place that tube in properly. So what, some of the other that we used to do, COPD, asthma, pulmonary edema, all of these type of patients, but they needed to be responsive. So that was kind of one of the big parts. So contraindicated apnea, once again, like I said, you're not unable to get that epiglottis out of the way otherwise. Head trauma and mid-face fractures, we're not going to, and then anatomic abnormalities as well, we're not going to do them. Now, if they do have some blood clotting abnormalities, I would probably, or if they take anticoagulants as part of a regimen, I would be thoughtful about trying this procedure on them, because it's pretty traumatic procedure in the first place. And then if they have some clotting issues, it's going to make a real mess, and your partner will not appreciate the mess that you've left them to clean up. So some of the advantages, though, they can be performed on a responsive patient. There's no need for a laryngoscope. The mouth doesn't need to be opened. It doesn't require a sniffing position, so you start to open up a little bit. Patients that may have a possible spine injury, it's inserted through the nose, so they can't bite the tube, and then it can be secured more easily than orally inserted tube to an extent. Disadvantage, it is a blind technique. So in my opinion, it comes down to two things: positioning, and then honestly, comes down to some luck as well. Confirming the proper tube position requires diligence to be able to listen well and be able to hear that. And then some of the complications are that there is a lot of bleeding. A lot of times there is a pretty good amount of blood, because this is a pretty rough technique. So now if you already have a potentially compromised airway, and now you're going to throw some additional blood down into that airway because of, as you can imagine, things are being scraped as you push it through there. That's why we want to use a much smaller tube than what we would oral tracheally, but it's still, for the most part, going to cause some issues. So the equipment, same as for orotracheal intubation. You're going to want to select a tube that's slightly smaller than the nostril. So, if we would put in a 7.5 normally in an orotracheal, I'd probably put like a 6.5 or maybe even drop down to a 6. You just do not want to meet a lot of resistance, because you got to understand that you're going to cause some damage. Some tubes are designed for blind method. I believe we still have one here on campus. So if we do, let's look for that while you're in here and get a good gander at that guy. And then some devices allow confirmation of intubation without placing face next to the tube. They have we have a few here. They're called a whistle tip, I believe. And what it does is, as the patient breathes out, it blows air through that tube, as you can imagine, and it lets out a whistling noise. Well, what you're doing is you're waiting for them to take a big deep breath, and as you do, you drop that thing through, and then when they breathe through it again, then you can hear that whistling noise again. So patient spontaneous respirations, they guide that tube. It's advanced as they inhale. So what I always advise is you go ahead and start feeding that tube. You'll hit the little wall of where their airway is, their trachea, and it'll cause them to gag. You back it off just a little bit, and you're listening to whenever they take a deep breath. As they take a deep breath, and you tell them, if you're able to instruct them, you tell them to take a really big deep breath. But if not, they're just taking a breath. As they take that breath, imagine the airway opening up, and you've pushed that thing down into it. And then you have the whistle tip on it. So then, as they exhale, then you're going to hear that whistle. So you insert the tube into the nostril, bevel facing towards the nasal septum. So think about that. The bevel needs to be facing the septum. Manipulate the head to control the tube tip position and maximize air movement. Take a big deep breath. Gently advance that guy through there. Soft tissue bulb on either side of the airway. The tube is probably in the piriform fossa, so we don't really want to. We want to be thoughtful about that, of what can happen. Once it's in place, inflate the distal cuff. Obviously attach a bag mask device. I get talking too fast. Clean up any secretions. Secure that tube with some tape, and then document the depth again. Oops. So digital intubation. So here we're talking about it involves directly palpating the glottic structures and elevate the epiglottis with your finger while guiding the ET tube into the trachea. It's an option in extreme circumstances. Never done it, and I wouldn't ever plan on doing it as well, just because I'm always kind of afraid people are going to bite me. So you got to get your hand in there. Somebody has a hypoxic seizure or whatever. I mean, that just sounds like a recipe for bad luck. Next thing you know, you've got a couple of fingers and a nub, just a little finger stub left. So I'm not going to do that much. So I'll leave that to you young heroes to get out there and do those things. But the advantages in case of equipment failure. So if you're not if your light bulb quit working, you're unable to see, or your laryngoscope, whatever, it spontaneously exploded, then you're able to do this. The primary disadvantage requires placing fingers in the patient's mouth. So, I'll let you think about that, but it's really easy to get bit or to have those gloves tear and you get their spit all over you and everything else. So, absolutely contraindicated if the patient is breathing, not deeply unresponsive, and has an intact gag reflex. So this isn't something that you're going to do to a conscious patient. But like I said, I'm a worst case scenario guy, so I'm thinking that they might have a seizure. Even if they're dead, I still just think maybe they might have a seizure. So major complication obviously is going to be the misplacement of tube because you're not able to guide it quite the way that you want. So you're still going to do a lot of the things that kind of the same way, prepare equipment. You're going to get 1/2 to a full size smaller than if you were able to use your laryngoscope and everything. You're going to the tip of the tube is guided into the trachea. That's going to be with your hands. Sniffing position is not required. Insert a bite block. Once again, I still don't trust all this stuff, but you insert that bite block and hopefully that's going to allow you to not get bit. Hold it in your right hand, insert it into the left side of the mouth, and then you advance the tube. So once you feel the cuff pass about 2 inches beyond your fingertips, you stabilize it and withdraw your fingers, and then you inflate the cuff. Attach your bag, and then ventilate. And then you're going to confirm that all of your same ways. So it's kind of a fun thing to do on the mannequins because it's just kind of old school and medieval. But like I said, in real life application, I don't know how many times I would do that. We're not going to hit too much about this. Transillumination techniques, probably not something that most of us are going to do, but you have a bright light source placed inside of the trachea, and it gives you a well-lit airway so you can see if it goes through. It's indicated when other techniques have failed. Contraindicated, intact gag reflex, airway obstruction, may be difficult in some patients. No laryngoscope. It doesn't require visualization of the glottic opening, and then it's safe with possible spinal injuries, but it does have to require some special equipment as well as you being good at doing this. And so as you can imagine, if you're using a light to light everything up, if you are in a well-lit area, that could definitely cause some problems for you. And then your complications are that it's going to go in the wrong place. So it's a device with a rigid stylet and a bright light source at the end. The light should shine laterally and forward. Hang on a second. Yeah, it should laterally and forward. So the stylet must be long enough to accommodate a standard length ET tube, and you also, of course, you're going to need a method of securing the stylet within the tube. So you're just bending those, up to where that it's not gonna go through. Pre-oxygenate. Choose your tube. Check the cuff. Lubricate and insert the lighted stylet. Now remember that it's the lighted stylet, so you want to be able to see through that guy, or the light. You're going to be able to see the light through there. Bend tube into the shape. Head in neutral position. While holding the stylet, displace the jaw forward, and then turn that on. Insert it into the midline of the mouth. And you can continue to read here. Continue insertion. Draw the wrist towards you. So once the light's visible at the midline, hold the stylet in place. Advance the tube. It keeps on going. I don't want to just read this to you. This is something that I've never done, and I've not even heard of a service, I think, that is doing this. But we still we're going to ventilate once we get done and secure the tube. Retrograde intubation, rarely performed in a pre-hospital environment. I've never heard of it, once again, done in an EMS environment. But a needle's placed percutaneously within the trachea via the cricothyroid membrane. So a wire's it's placed toward the head and through the needle upward through the trachea and into the mouth. And then the wire is visualized and secure, and the ET tube is placed over the wire and guided. So kind of similar to, we talked about that bougie and how we're going to slide a tube over that and slide it down through. This guide wire is the same kind of thing. It's going to guide you through there. So copious secretions in the airway, talking about indications. Failure to intubate would be another one. So lack of familiarity with the procedure, laryngeal trauma, distorted landmarks, some other issues. Complications, hypoxia, dysrhythmia, mechanical trauma, infection, a lot of bad things there. And a little more applicable, face-to-face intubation. So a lot of times people call this a tomahawk chop or tomahawk technique because of the way that you're going to hold the laryngoscope, because you're now flipping it over to where you have the handle and the blade is down at the bottom of your hand. You're now flipping it over. So this is going to be kind of a face-to-face intubation. So a good time to use this is in the event you're having to intubate somebody that's trapped in a car, and say the top already got cut and rolled off. You're able to intubate that patient while they're rolling the dash and everything off, while he's sitting there, and you're face-to-face with him. So it really, it's a pretty important procedure, because this is something that you may have to do, and you don't want to have to figure it out while you're in this call. So the laryngoscope is held in the right hand, and the ET tube is in the left. So everything's a little bit different, as you can see. Once the blade is placed, the head may be adjusted by pulling the mandible forward while pressing down. And you just, once you've pulled that down, you're able to insert your tube down through the cords. Hopefully, we'll be doing that in lab as well, and it'll probably make a lot more sense as we start to do it there. So a failed airway attempt, what are we going to call that? What are we saying with a failed airway attempt? So failure to maintain O2 saturation during or after one or more failed intubation attempts. So once they start desatting, if that's the case, that's a failed intubation, as well as a total of 3 failed intubation attempts. Out in the field, I always ask my medics to typically 2, sometimes 3. After 3, you've got to give it up. Whether that's an IV or a tube, you've got to give it up and switch positions and let somebody else have a look at that thing. Tracheobronchial suctioning. So, if you don't have to do it, it's a really good idea not to, because it comes with some issues. But it involves passing a suction catheter into the tube to remove pulmonary secretions. So number one, it must be performed by a sterile technique. And then some other issues is you're also going to be suctioning out the oxygen that's in their lungs, and it can cause some other issues within cardiac rhythms, especially if they do become hypoxic. So in the event that you decide, though, that you need to do this, first thing you're going to be told is we've got to get these guys pre-oxygenated well. You may actually need to throw a little bit of fluid down in there as well. So 3 to 5 mils of sterile water down that tube to kind of loosen up some of that thick stuff. Then we're going to gently insert the suction catheter down the ET tube until resistance is felt. Of course, you're going to apply suction as the catheter is extracted, just a simple EMT suction technique. Do not exceed 10 seconds as an adult. So once again, if you kind of need to breathe, I suggest not suctioning longer than your breath. And then you, when complete, reattach the bag mask device, continue ventilations, and reassess your patient.